Good afternoon, everyone, and welcome to today's session number 5, COVID-19 Best Practices in Nursing Home. I am Susan Ryan, the Senior Director of the Greenhouse Model, the Greenhouse Project, and I'm really excited. This is more than a webinar. We are using the Project ECHO model, which really leverages technology to be able to share best practices through case-based learning and different scenarios, so that we can monitor and improve the outcomes. And I think if ever there's a time to really be focused on really improving our outcomes and really tapping into our collective wisdom to really understand how we can mitigate the spread of this COVID-19 infection, now is the time. I'm excited for today's session, COVID-19 and advanced care planning, and really excited to be able to introduce our speakers. But before we get to that, I'm going to ask Janet Wright, my colleague, to introduce herself and go over just a few housekeeping announcements.
All right, thank you, welcome. You will be in listen-only mode today. We do encourage you, however, to use your webcam so that we can get to know you. We ask you also if you would that there's a chat box down at the bottom of your screen. We will be using the chat box for any technical issues and also for our question and answer portion of the session today. But we also ask you to enter your name and your organization so we know who is with us and where you're from today. The session will be recorded, so probably, if not today, by tomorrow, you will be receiving a copy of the recording that you can listen to at your leisure then.
Thanks, Janet. And also supporting today's session is my colleague, Marla DeVries. Marla, you want to introduce yourself?
Hi, everybody. Marla DeVries. I'm the Director of Resource Development for the Greenhouse Project. I'll be popping in and out for the Q&A time, and I'll just say there have been some really good questions submitted at registration, so I'm eager to get to them and really encourage, as you go through the presentation, to put your questions in the chat box.
Great. So this next one is where you all can get involved. So take a look. Following this slide, I want you to make a determination where you're calling in from. We like to kind of figure out which part of the country our participants are phoning in from. So Janet, if you want to launch the poll, and then we'll have everybody submit their answers. There you go. So select the region in which you reside. We'll just take a couple moments for that. Okay, just a couple more minutes, couple more seconds, I should say. Okay, Janet, I'll let you stop the poll and share the results.
On a pop-up window came in front of my poll thing. Okay.
There you go. Once again, it looks like the Northeast, that 30% of you are from the Northeast, but we have a pretty close, 26% are from the Southeast, and fewer are from the Midwest, about 12%. We have 8% of you that are calling in outside the US, 8% in the Pacific or Rocky Mountain area or Southwest. So grateful for all of you, wherever you are calling in from, really grateful that you have joined us today. I'm going to have our panelists introduce themselves, and I'm going to ask Dr. Al Power if you would introduce yourself first.
Hi everybody, this is Al Power. I'm a geriatrician, educator, consultant based in Rochester, New York, but on the road, at least I used to be on the road back when it was now I mostly do webinars and Zoom meetings. I'm also the Schlegel Chair in Aging and Dementia Innovation in Waterloo, Ontario, but like most of us, I'm banned from Canada for the time being. So once again, lots of distance work, but I'm glad to be here with everybody.
We're glad to have you as always. Thank you. Eric Reguera from the Jewish Home Family.
Hi, good afternoon. My name is Eric Reguera from the Jewish Home at Rockley here in Bergen County, New Jersey. Thanks for having me again. It's always a pleasure being a part of the Greenhouse. Thank you.
Always grateful to have you, Eric. Thanks so much. And now Dr. Marie Aydelotte. from Jewish Senior Life.
Hello, everybody. This is Marie Aydelotte. I'm the Medical Director, Chief Medical Officer here at the Jewish Home of Rochester, Jewish Senior Life, and it's a pleasure to be here. I've been involved in greenhouse work for many years and very pleased to be asked to be part of this talk.
We are so grateful you're here, and I look forward to your presentation later on. But I'd like to introduce our first presenter, and that is Brynn Bowman. Brynn, you want to introduce yourself, and then I'll have you transition right into your slides.
Hi there, good afternoon, everyone, or I guess midday for those who reported in from the West Coast. I'm the Chief Strategy Officer at the Center to Advance Palliative Care. We are a nonprofit that's affiliated with the Mount Sinai School of Medicine in New York City, but we work with healthcare organizations nationally, whether they are looking to build out specialty level palliative care programs or embed a palliative approach to care in their care operations. So very grateful to be asked to speak and join the hour with you all today. I'm going to go ahead and share my screen. So our topic today is advanced care planning. And why I've titled this presentation with the word empowering is that I think, I don't have to tell folks on the line that for all of us, whether you are a clinician providing care, the leader of a nursing home or healthcare organization, or certainly a patient or a family, these are uncertain times. And I think most of us feel that in some sense, they're a little out of control. Like we have lost a sense of power and a sense of capacity to plan for the future and predict what's coming next. And so I'd like to make the case for a few minutes today that advanced care planning is an intervention that can restore a sense of planning and empowerment, both for long-term care residents and for the people caring for them. And while this talk and the topic of this echo today is advanced care planning, which is a formal process that clarifies and documents patient preferences if the worst should happen. So a formal communication tool that is helpful for families and for clinicians and healthcare staff to understand what a resident would want if the worst should happen with respect to certain interventions. The underlying message that I'd like to impart today is that while advanced care planning is that formal process, the quality of that conversation between their caregiver and the person living with or planning against an eventual serious illness is really, really important here. Advanced care planning can document a person's wishes at a point in time, and it's important that that be done and be done again at intervals. But it's also the way that a healthcare team understands how that resident is thinking and feeling and planning for the future. And the quality of that conversation and the confidence that a healthcare professional feels having that kind of conversation with a resident is really, really, really critical. So I'm going to start today with a case study. And in this case study, we'll be thinking about a patient named Deborah. Deborah is 89 years old. She is a resident of a nursing home. Her family is very close. They live nearby. They visit her regularly. She's been a long time member of a church, and a group from her church comes regularly to pray and sing with her, and she looks forward to these visits. She derives pleasure and purpose from that communication and time spent with her community and her family. She eventually develops increased fatigue and her appetite is reduced. And because the other people in her nursing home have tested positive for COVID-19, the staff decide that she should be tested and placed in isolation because of her symptoms. And so of course this means that Deborah is unable to receive visitors. The staff who enter her room for her sake are wearing masks and eye protection and gowns and gloves and feel to her likely like an alien walking into that room. Her test comes back positive, so Deborah does in fact have COVID-19. Her symptoms start to become worse. She's agitated, she has a high heart rate, and she's having problems breathing. Her family has seen all of the news. heard all of the horror stories, and they are really worried about Deborah ending up in a hospital where they feel she might be even less safe and even more isolated. So Deborah is frightened in this room. She doesn't quite understand her diagnosis, but she knows that she has a hard time communicating with staff, and there are all of these layers of PPE between her and the people that she's used to receiving care from. When the staff try to help her talk with her family so that they can feel more comfortable and help her feel less anxious, she has a hard time hearing over the phone, and she gets more and more uncomfortable and frightened. Oxygen isn't helping with her dyspnea, and the staff are really at their wits' end. How are they supposed to help Deborah in this incredibly difficult situation? So I want to stop here and talk about the sources of suffering on both sides of this equation. For Deborah, who had been used to a lot of social contact, both with the caregivers at her nursing home and with her family, she is lonely and feeling socially isolated, which is disorienting. She's terrified because she's having a hard time catching her breath, and she's altering through cycles of delirium, likely due to her infection and the change in her environment. For the people caring for her in that nursing home, they're feeling a lot of distress because they can see that Deborah is suffering. They are very anxious, talking to the family who's distraught and worried about the right course of action. And the staff themselves are uncertain about what to do to best care for Deborah and honor the person that they've known and loved in the time that she's been at the nursing home. So the staff set up a video conference call with Deborah's family from her room so they can see her. And what they see is that she's having labored breathing, that she looks like she's in some distress, and she's not able to talk on the phone during this family conversation. So what I'd like to run through is an example of a conversation between the staff at Barbara's nursing home and her son about what her goals might be in this situation. I know our time is short, so I'm not going to read line for line, but I'd like everyone just to spend the next 30 seconds reading through this interaction between the nurse from the nursing home and Deborah's family. So the staff at the nursing home, first of all, gets the information that they're talking to Deborah's son, who is her designated healthcare proxy. And they begin the conversation by asking the family's permission, and in this case, particularly Deborah's son, if they can have a conversation about what comes next for Deborah and what she might want. This is a really effective way to start this conversation because, again, it gives families a sense of empowerment, that this is a conversation that they can opt into on behalf of their mother, their loved one. So the nursing home staff member begins by saying, I need to give you some background. Most people who get COVID have a mild illness, but people like your mother who have pre-existing medical conditions and are older are at higher risk. So the clinician from the nursing home goes on to warn Deborah's son that if her infection from the COVID becomes more severe, there is a chance that that infection could take her life. Her son, of course, is afraid and is nervous in that moment. And the nursing home clinician says, it's not what any family member wants to hear. Given that if the worst case scenario happened and she was going to die, do you think she would rather go to the hospital or be at home to stay here at the nursing home? The son has some information based on conversations with the family. Their family is nervous about sending Deborah back to the hospital. But the clinician wants to make sure that this is a decision that comes from what Deborah would want, rather than a consensus decision on the rest of the family. And so they appeal to Deborah's son's love of his mother. I can see that you want the best for her. Absolutely, he says. Let me put it another way. If she didn't have dementia and was her old self for a moment sitting here with us, and she understood COVID and what would happen if it got bad, what would she say? Her son says, she would say, enough already, I'll stay here. Just keep me comfortable. But I don't know. It sounds to me like you know what she would say, but you're saying, I'm not sure. Did I get that right? Yes, we're not ready to lose her. It's not the kind of decision anyone wants to make. It does sound like you two may have talked about this. And so at the clinician's probing, the son does recall a memory. When my mother was first diagnosed with dementia 10 years back, she was just a little forgetful, nothing big. We were driving to the park to walk the dog, and she said to me, "Remember, when I can't do this anymore, it's time to let me go." The clinician goes on to say, "That kind of memory is a gift. Would it be okay to honor that?" And the son replies, "Now it's clear to me. Let's keep her here at the home, right there. But she looks so uncomfortable. Can't you do anything for her?" So I want to point out two other key pivotal moments in this conversation. The first is when the nurse at the nursing home asks the son to step into his mother's shoes and think from her perspective, from her point of view, about what she might want in this conversation based on everything he knows from a life with her. And second, the nurse helps the son use that memory, use what he knows about his mother to make a decision that he thinks would honor what she would wish in this situation. So what did the nurse accomplish? She was able to help the son really evoke the voice and the wishes of the resident, support him to honor those wishes, and together arrive at a decision to keep her in the nursing home and to make sure she is comfortable. What the nurse also did in that scenario was to help the son grapple with his distress and the anticipatory grief that he's feeling, because it helped him in that moment to recall what his mother would wish in this scenario. Certainly, having heard Deborah's son's account of what she'd spoken of throughout her lifetime, if a moment like this came up, it helped the nursing home clinicians to feel like they were really providing the kind of care plan that Deborah herself would have wanted. So distress was relieved on both sides of this equation. So I hope that this story conveys what a powerful intervention that conversation can be. And I want to now take a moment to step back and put all of this into context, because what we've just seen is an example of a goals of care conversation. That is one type of conversation that helps nursing home residents and their clinicians understand what is important to patients and families. And I'm going to talk about this larger mix. So what's the difference between a conversation with residents and their families about prognosis, about their goals of care, and a formal advanced care planning conversation? When and why would you have any of these conversations? Are they in some cases the same thing? I think the language used around these types of things can be pretty fluid and at times inaccurate. And so I want to take a step back and think about the goals of any of these conversations. And to do it, I'm going to use a few lessons from a learning community that CAPC has administered over the last year. This was a learning community of PACE programs, but I think the learnings that came out of those 10 PACE programs are really applicable to the nursing home setting. When thinking about these types of conversations with patients or with residents, the learning community thought three things were really important to consider. One is the timing. When is it appropriate to have an advanced care planning conversation with the resident? And when and at what interval or based on what trigger is it important to sit down and have a broader goals of care discussion with that patient? An advanced care planning conversation, again, documents for specific interventions, what would that person want should the worst happen? Whereas a goals of care conversation happens in a moment of crisis where real-time decision-making is happening. So I'll talk about when and how those conversations can be had. Really critical to this process is understanding what matters to residents and understanding family dynamics. Who is the resident's healthcare proxy? Is there conflict among family members that is going to make decision-making difficult or potentially painful? And where clinical staff have a chance to intervene and help families solve problems. And again, the quality of these conversations. Do the staff having these conversations feel like they have adequate training and are prepared to have a really tough and potentially anxiety-inducing conversation with residents? Whether it's about sharing bad news, about imagining a worst case scenario, or about making a difficult decision in a moment of crisis. And so staff training is a way to improve the quality of conversations and again, relieve moral distress on the part of nursing home staff. So I did not have time, unfortunately, to play all of us this video interview with Atul Gawande, but I will send the link out to everybody afterwards if you're interested in watching the full video. It's 6 or 7 minutes long. Atul Gawande is a brilliant healthcare writer. His pieces have shown up many times over the years in the New Yorker. And he is also the former leader of Ariadne Labs out of Harvard Medical School, which has the Serious Illness Care Program, a program focused on serious illness conversations. So conversations with people living with a serious illness about what matters to them that then go on to inform a care plan. And about this topic of advanced care planning or goals of care, he says, try to take a different frame. Rather than starting with an advanced care planning conversation about whether, for example, a patient would like CPR or to go on a ventilator if they became very ill, start by talking to residents and their families about their understanding of what their illness is and their interest in talking about what to expect. Start by eliciting residents' fears. If they were to become sicker, what is the thing that they're most concerned about? Is it experiencing pain or discomfort from symptoms? Is it that they may not survive to see their great-grandchild be born? These are going to be different for every person, but really important to helping a clinical care team understand how best to support a family in making decisions. What gives that resident hope and strength in the face of a serious illness and allows them to feel a sense of purpose as they struggle with that diagnosis? And what trade-offs are they willing to make if they do become sicker? Starting with this frame not only helps deepen understanding between the healthcare professionals talking to that resident, but helps that resident or their family members feel more comfortable with the conversation because it's personal. And when that frame is the frame that's used first, many professionals find the conversation easier to start and that it can naturally lead to questions around medical interventions, which can then be documented in an advanced care plan. So, for example, what about CPR? If we go back to our resident, Deborah, the nurse at the nursing home asked his son, after the section of the conversation we've seen where she understands, what Deborah's son thinks she would want, given her COVID diagnosis, the nurse has a better entry point to ask Deborah's son, if Deborah's condition gets really severe, what does he think she would want? So she says, Mr. W, is it okay if we talk for a minute about what will happen if her heart stops and she dies? Deborah's son says, I guess so. We need to ask you about CPR if your mom's heart stops and she dies. To be honest, given her condition, if we need to put her on a breathing machine or do CPR, she will have to get that in the hospital. And given her age and condition, there's unfortunately a very high risk that those interventions won't work. The odds are against us. My recommendation is that we accept if her heart stops and she dies, that we should not put her through CPR, but allow her to pass on peacefully. I suspect that may be hard to hear. What do you think? Now, this is a recommendation that nursing home nurse is able to make because she understands what is important to Deborah, what are her values, because she's already had a conversation with Mr. W, Deborah's son. And so starting from a broader frame of the conversation about what matters most to Deborah and her family allows that nurse to get more specific and talk about interventions that would show up in an advanced care plan. So block and tackle for advanced directives, what is important to consider? And I think what we can see from this case study, is that it's critically important for any long-term care resident or any patient in any setting that the care team know who is the surrogate decision maker for that person or the healthcare proxy. And so upon admission is a really good time to have a standard operating procedure for either identifying who is a healthcare proxy or helping that resident understand the role of a healthcare proxy and to make that decision if they have not in the past. In terms of completion of POLST or MOST forms, physician orders for life-saving treatments. So these are the advanced medical orders about specific interventions like CPR, like hospitalization for a nursing home resident, like care delivered in the ICU. For patients who are very ill and have a short prognosis, these advanced directives are critically important, again, because they are orders. And if a patient's wishes for these specific interventions have been documented in that advanced directive, that is an order that can be communicated to not just nursing home staff, but any other members of a care team or people caring for that resident in other settings. Staff need to be well trained and comfortable to have conversations about these interventions because it's a difficult thing to do. And scripts and training are really helpful in this regard. And at the end of this presentation, I will point out several resources that are free and publicly available and that if you're interested could be used in your organization. A key point here is that these conversations are not one and done. So is it important, certainly, to identify a proxy when a resident is admitted to a nursing home? Yes. Is it important that that patient's advanced directive be on file? Yes. But a conversation, as the slide says, about a hypothetical scenario in the future is really hard to implement if the worst should happen. Not only that, but people's wishes can change over time. What's important to people can change over time. If they become sicker, what's important, or the trade-offs they're willing to make around certain treatment decisions can change over time. And so it's really important that that clinical care teams return to this conversation about people's goals of care regularly, and certainly at key moments where, for example, a new diagnosis is received or a person suddenly becomes sicker. And if that person's wishes have changed, those changes should be reflected in an updated advanced directive document. Best practices that we've seen from organizations who have integrated standardized advanced care planning and goals of care conversations is to make sure residents and families know what the medical condition is and what they can expect from that condition in the future as much as is able to know. This is the starting point for any sort of decision making or imagining any type of hypothetical future interventions. So it's really key that both the residents and their family, if they're involved in decision making, understand what baseline is, what that person's medical condition is. And secondly, start by finding out what is important to that person at this time in their life. And if time were to run short, how would they want to live their days? What does quality of life mean for that resident, knowing that they have a serious illness, whether it's COVID or any other illness? And finally, and this is a really difficult one, allowing for silence in these conversations. It's a key teaching point for clinicians who are having these discussions and builds trust on the part of patients and families that clinicians are listening to what they have to say. So I'm going to wrap up by talking about resources that are specific to having goals of care and advanced care planning conversations during this COVID era, which unfortunately we are not out of yet. What we're looking at is CAPC's COVID-19 toolkit. The URL for this toolkit is printed at the bottom of the slide. The first box that you see when you hit the toolkit is communication. If I had clicked into that communication box, you would see different topics listed here below. Each one of these is linked to the actual toolbox on the website. And these sections contain conversation scripts, so specific phrases recommended that healthcare professionals can use in an advanced care planning conversation, in a conversation about goals of care, in a family meeting, or should a resident become very ill, helping that residents' family say goodbye to them if face-to-face communication isn't possible. These scripts are something that can really help boost confidence for the healthcare professionals having those conversations, again, because they can induce a lot of anxiety. And so it's helpful to have that tool. Most of these conversations, we have a video example of the conversation being had between a clinician and a family member or a resident. So clinicians can actually see and experience what that conversation might feel like. Other resources include virtual office hours. Again, these are free and public to any professional, any organization. Virtual office hours are a chance for, if you've used the communication script, if you've watched the video and you have questions or you want to practice, you can call in and talk to a communication training expert. And CAPC has also curated a list of communication resources from other national organizations specific to COVID, because we know that these are conversations that have not been had before in this particular way. So I'm going to wrap up there. I would encourage everyone, if you're interested, to visit the palliative care provider directory linked here. This lists community-based palliative care programs that may be able to provide either telehealth or in-person consults for patients whose needs are particularly acute, who are living with COVID or another illness in the nursing home. And if you have questions following the Q&A and the echo session today, feel free to reach out and shoot me a note. Thanks very much.
Brynn, that was fantastic. Thank you so much. And I will just testify, I've been on the website, I've kind of taken a tour through the website, and there are tremendous resources. So we are grateful that CAPC has made them free and available to everybody during this particular time. I want to invite you to put your questions in the chat box that you might have for Brynn. But what I'm going to do is open it up to our panel. And Eric, I'm going to start with you to see if you had any questions or comments for Brynn about the presentation.
Well, just a quick comment, actually. Again, based on our experience here during the first month of the pandemic on early March, we had the same strategy. And what we did was we reviewed all the advanced directives and the code status of our elders. As I clearly remember, our CEO, Carol Elliott, spoke to one of our local partners, hospitals here in Bergen County. When the surge is starting happening, he said, you know what, as much as possible, please do not send the elders in the hospital. And this is what he said, it's a war zone in the hospital. All the units are turned into the COVID floors. They're running out of ventilators. So again, when we experience this, when we share this to the family members, when we're speaking to the family members and elders, we explain, to them what hospitalization will be like. This is what's happening out there. And, I would give kudos to the social workers and to the nurse managers, because they took a lead on this, because number one, they have a strong relationship with family members and elders. They have that trusting relationship as well. So when they're communicating, when they're talking with this, everybody's on the same page. They're comfortable to each other. And it really did help. Since March until June, end of June, we transferred 5 elders to the hospital due to COVID. And I think one of the reasons with that is because of advanced care planning and communication. It did really work. I just want a quick share or an example, talking about dignity and quality versus, dying in the hospital, one elder alone in a ventilator. We have an elder up in one of our units here, and very sick. He became very sick. One of the first elders who became very sick from late March, and the family agreed that he stayed here and with us. We'll do the best we can to manage, the treatment and treating about the COVID. He even said to the nurse, the nurse has a long-term relationship with it. Do not leave me alone at the bedside. And at the end, this nurse didn't leave him alone. Talking about quality and dignified death, our nurse is by his side until the end. You cannot replace that, if this elder will die in the hospital on a ventilator. Can't, so that's a perfect example of advanced care planning.
Yeah.
Wow.
And
Yeah.
I'm curious, Eric, did you go back when you were anticipating COVID, did you go back and check in with residents about their advanced care plans?
Yes, it's ongoing, actually. We didn't stop. Until now, we're still talking to family members and elders. I know it's a kind of uncomfortable topic, but you have to be realistic and you have to be truthful and honest. Because again, what we experienced in the beginning, I mean, we're sharing that to the family members. And again, I don't want to say that, you know, we know more than the others, you know. However, you know, as you know, in this pandemic, we're the epicenter of the COVID in March and April. And we lessons learned, you know, we share it to the family members and elders. Even new admit elders, subacute elders, when they come in, you know, we speak about this based on our experience. And it does really work. It does really work.
That's powerful. Thank you so much for that. Dr. Power, do you have a question or comment for Brynn?
Brynn, that was a really fabulous presentation. Thanks so much for doing that. And there's really not much I can add to that because it was so beautifully done. In light of a question that's coming up that I know you'll answer more fully, I guess I would just make the comment from the standpoint of people living with dementia that even though they may have a designated surrogate and even may be determined not able to make all those important decisions, you can still talk to people with dementia. They can still tell you whether they're happy or not. They can still make decisions about what they like and what they don't like. And even people that don't use words may spit out pills. They may pull out feeding tubes. And while they may not sign a form, these can often be used also in conversations with surrogates as indications of people's preferences. And the more clues that we can use to help those really burdened family members to make difficult decisions.
Great, Al. Thank you so much. And finally, Dr. Aydelotte, did you have a comment or a question for Brynn?
No, just that I think it was a fantastic talk, and I hope people will use the resources. We certainly use the CAPC resources a lot here at the Jewish Home.
Well, that's great. I'm glad to hear that. And what a perfect opportunity to segue to your presentation, Dr. Aydelotte. And what I'm going to ask those of you who might still have questions, we're going to do one Q&A at the end of Dr. Aydelotte's presentation. So if you still have questions for Brynn, feel free to put them in the chat box. Dr. Aydelotte, please go ahead.
Okie doke. Okay, so I hope that my talk will build quite a bit on what Brynn's talk covered, and I'll try to go through it fairly quickly to leave some time for questions. I did put some background about the Jewish Home on here. Jewish Senior Life has a nursing home, 238 beds, and other types of unit that are listed. The one thing that is a little different is that we have a very large subacute rehab program, 88 beds. So it's almost a mini hospital within our nursing home. And we did build three-story greenhouse homes several years ago. So we actually have 108 greenhouse living elders. We're also unique because we have an in-house medical staff with 3 physicians and 5 nurse practitioners and physician assistants. So very different from a lot of places. This is kind of what makes us unique. We do have a big focus on palliative care. We had a big palliative care grant, and as I will show you, we have a lot in place as far as discussion of prognosis, planning of advanced directives. We do contract with a local hospice as well. And like all nursing homes, we have a lot of people at end of life. We usually have around 20 on hospice at any one time. These are just pictures. This is the big tower. And then this is one of our greenhouse cottages. They all look like this. They're 3 stories. This is how they look inside. And right now, what we have been doing, and I recommend for all nursing homes, that at time of admission, as Brynn said, either get a copy of the healthcare proxy that the person has already made, and most of our people have done that, or if the resident is able to designate someone to make decisions for them, take the time to do that at time of admission. And like Al said, even residents with dementia, they often know who they would want to make decisions for them. This is a simple form. In New York State, it's available, you know, online from New York State, and it does not need to be notarized or go through a lawyer or anything like that. We have, because we have our on-site medical staff, the medical staff sees every elder who is admitted within a business day for a history and physical. And as was discussed before, that goes into reviewing all of their diagnoses, prognosis with either the elder or the family. And all of our admission folks have advanced directive most completed at time of history and physical. So most is medical orders for life-sustaining treatment. That's what we have in New York State. And virtually all of our elders have it. Some of them say full code, most of them do not. Right now, even at the beginning of the pandemic, at least 75%, around 75% of our long-term care residents already had chosen do not resuscitate. 50% have chosen no hospitalization. Why does that happen? It's because we have a fairly high level of service here. We have either a physician or an APP on site 7 days a week. We have pharmacy services, lab services, x-rays 7 days a week. So we have a pretty high level of care, and many people just do not want to go back to the hospital. At the start of the pandemic in Rochester, we didn't know what was coming at us. We were very scared, just like everyone else. And we prioritized looking at advanced directives, and all the elders that had full code status, we took time to discuss with them and their families what their wishes were, had anything changed, looking at what might be coming our way in terms of COVID. This is very time consuming, I'll tell you. And I remember that we sat down and divided up who was going to call who, and I took 2 people a week that I did, because each one takes like an hour. You have to call and discuss and talk about prognosis. But for people to know, you can complete an advanced directive over the phone. You just have to get another person to witness it. So it can be a verbal consent. You can be one of the witnesses, and then you put your phone on speaker and take it to someone else, and they can be the other witness. So anyway, here's my case. Basically, the reason Carol talked me into this is that I had a good case. So Rita, a 97-year-old elder on our neurobehavioral unit with advanced vascular dementia, atrial fibrillation, legally blind. At time of admission, she had an only child, her daughter. She said Rita had always told her she wanted everything done. She was full code with hospitalization. Then we had a nurse who was married to another nurse at a nursing home that had a big outbreak. Our nurse got sick with COVID, and we tested all the residents on the unit, and the one that had the symptoms was Rita. So next, immediately I called the daughter, and the important point here is that I had a relationship with this daughter. On the day of admission of Rita, I take care of everyone on our neurobehavioral unit. They're all very complicated, a lot of aggression and behaviors. I call all those families and go over advanced directives in detail on the day of admission. So I had already had a 40-minute talk with this daughter because she was so unrealistic about Rita's prognosis, okay, like a few months ago. So I knew this daughter that I was calling, and I think the message from Brynn's talk is that good nursing homes, they have relationships with these families, and having that relationship and trust is what makes it possible to have these difficult discussions. So I called the daughter and had a frank discussion about Rita. I mean, 97 years old, multiple medical issues, and now COVID. That was very scary for me and the family. So I'll put in a little just information that I put into my discussion, and then we'll talk about what happened to Rita. So as everyone is aware, the severity of COVID illness relates to not only age, but comorbid illnesses that they're all found in nursing home residents. the functional impairment that nursing home residents have also contributes. The statistics are very grim, that almost a third of nursing home residents with COVID will die. And for patients that are admitted to a high level of care, such as an ICU with a ventilator, prognosis is even worse, probably over 2/3. So not good, but not saying that nursing home residents with COVID don't recover, because they also can. So some of the discussion with family members is informational, discussing that resident's previous medical conditions, also talking about the symptoms and the range of symptoms in COVID illness, talking about what we could do here in the nursing home, what the hospital could do. And in the nursing home, keep in mind, we can certainly do antibiotics, oxygen, fluids, and there's new information about other medications that we could potentially try, steroids, anticoagulants, that type of thing. But the main thing I tell families and residents is we want to have this discussion because we want to keep you in the driver's seat. I've said that many times. And let them ask questions back to me after I've kind of gone over things with them. Of course, this is much better to do before an acute illness situation occurs. So to continue the case, the main factor in discussion with this daughter, even though Rita had always said she wanted to go to the hospital and have everything done, the daughter didn't want her to leave because she liked the way Rita was being cared for at the nursing home. She liked the relationship with the staff, and she could not picture having her mother with strangers, no visitors. So the daughter that night opted for no hospitalization, and often the no hospitalization, in my experience, is the trigger for the no resuscitation, believe it or not, because families that want their person, especially families that want more aggressive care, they often get to this point where, yes, they want the aggressive care, but they don't want their person to go anywhere. And then we say, well, we can't do the resuscitation here. It goes with the no hospitalization. So that's part of the discussion. So we moved Rita to our COVID wing, and she looked terrible. I was absolutely sure that her prognosis was days. The staff was spoon feeding her several days. Over 2 weeks, she lost 30 pounds. Family came around to a comfort care approach. And wouldn't you know, she got better. So I had to put that in because, never underestimate people in their high 90s and low hundreds. So her fever and cough resolved. She did not get a secondary pneumonia, and we didn't put her on antibiotics. Her COVID test took a long time to turn negative. In New York State, you need to have a negative COVID test twice to come out of the COVID unit. So it didn't turn negative for a long time. And well, who knew, after about 6 weeks, she started eating and gaining weight. And now she's back to baseline on the neurobehavioral unit, quite scrappy and having behavior issues. So I thought it was amazing, really. So that's why I put the case in, and that is the end of my talk. But I'd be very happy to take discussion questions. I put up some websites that I used, as well as a really good tool for communication that is at the other link there. And I'm gonna get rid of my slides, and Brynn and I.
That was fascinating, Dr. Aydelotte. That was so incredible. What a fascinating case. I appreciate you sharing very much. So once again, put your questions in the chat box, and I'm going to go now to our panelists. And Brynn, I'll start with you. Any questions or comments for Dr. Aydelotte?
Well, I really appreciated that that you made the point that it was the trust that the daughter had in your care that allowed you to have that conversation when it was a moment of crisis. I'm actually going to borrow a question from the chat box earlier, which was, how do those conversations change depending upon the capacity of your nursing home to care for a person? I wonder if you would want to comment on that for Rita's case.
you're saying as far as having less medical staff on site, that type of thing? Is that what you're talking about?
Yeah.
Well, I think many of the interventions that we're talking about are just good nursing care, oxygen, and obviously if someone is doing poorly and very short of breath, providing medication like morphine, like liquid Roxanol under the tongue. So I think it's really tapping into the family and the elder, if they're able, to look at what their goals are for that person, given that they have a very serious illness. And they need to know that there's probably about a third chance that their person won't survive, but there's about a 2/3 chance that they might survive. So really looking in, if your person is this sick, where do you want them to be, and what is most important to you in terms of symptom management, quality of life. And if families are at all realistic, they're usually very tuned into symptom management and quality of life. The one thing I'll just put in that's very, very hard for everyone is the visitation limitations. I think that is so very traumatic to residents and their families.
Great, thank you so much. What about you, Dr. Power?
Thanks, Maria. That's a great case, and there's always a surprise ending, isn't there? But I guess maybe it's not a surprise. I guess before I ask a question, I guess I would argue that maybe being at the Jewish home, having the relationships, having a non-hospital environment, she probably had a better chance of survival than she would have if she'd gone to acute care, where she may have been pushed aside. For younger people, may have been prone to super infections and all the other things, delirium, over medication, things that happen in hospitals. So I think that's another thing family members don't realize, is that sometimes best care on site is better than what acute care has to offer. But for the rest of my comment, I guess I would just cede back to Melanie, who asked a question we didn't get to in the first half, and that is, where do you go when there's no when there's no surrogate and the person cannot decide for themselves? Guardianship is such a laborious process. What are some of the clues you would give people when they don't have a good surrogate for them?
Is that for me?
Yeah,
That's for you.
That's a really hard question. I'll respond to the first part of it first, which is, yes, I agree with you that care in the nursing home setting can be better. We steadily discontinued this woman's medications, and what got her better, well, it was a lot of nursing attention, hovering, turning, positioning, and that spoon feeding, I think really did it for her. As far as the no surrogate, that's an extremely hard question. But to keep in mind that most people have someone, and in our state, even a friend can, an acquaintance or a friend can make decisions for the person and be listed as a surrogate. It's the rare person that has absolutely no one.
Thanks.
Eric, how about you? Question or comment?
Just a comment, Doctor, that was a great story of Rita, because we had same experiences here in our building. A few elders, actually, they're in their 90s, diagnosed with COVID, and again, with the help of the nurses and the CNAs, and also the management protocol, what we initiated here in the building, again, that keep changing, because every week and there's something new, and we keep the families up to date. I think it's a collaborative effort with the doctors, nurses, and the CNAs on how we approach and how we care for the elders. And there are a lot of success stories, like you said, Doctor. We think that, this is going to be the end, but it's not. And I commend all the staff about it, because we never give up. We never give up. And as part of our advanced care planning directives, we always explain it to the family members as well. What can we do in the building? What can we do it here? Because you know what? We're not going to give up. We will try our best to make sure that, we will do our best in order to treat the elder and to make her better, and to make the elder have a dignified death or a dignified life,
Mm-hmm.
So again, same stories, same experiences.
Yeah, communication with family is very, very important, and it's very difficult because it's time consuming,
Right.
But with the lack of visitation, we just really have to try to families in the loop and informed. And we've done quite a bit with, FaceTime and that for family visits, as I'm sure all of you have too.
Great, thank you so much. Marla, I'm going to shift to you to see what questions have come up that haven't been addressed yet.
Yeah, one from the chat box, and then I've got a couple follow-up that came in at registration. So if the nursing home is not a greenhouse home, do you have the same recommendations in terms of avoidance of the hospital? So, Al, you talked about best care on site, but anything that any of our panelists would want to add to that?
So I think I just want to come across that, I'm not making an across the board avoidance of a hospital. I want to encourage homes to discuss with families the seriousness of the illness, what hospitals can and cannot do. And I think the vast majority of families are going to choose, because it's mostly families, the place where their person will have the best comfort and quality of life. But there are families with different values, and we have some of them here too, not very many, who want their person in the hospital and often at end of life. So that is individualized, but as Al and others have said, the quality of supportive care is probably as good or better in the nursing home than in the hospital in many cases. As far as whether it's a greenhouse home or not, I don't think that should come into it at all, personally, because all good nursing homes are focusing in on greenhouse values, whether it's an official greenhouse home or not.
There were several questions on supporting elders living with dementia. So here's one. What can family members do if physicians are reluctant to honor the advance care plan made by a person with dementia before diagnosis?
Well, legally, physicians have to honor the advance directive made by that person. Maybe that helps a little bit. The healthcare if the person loses capacity, the healthcare proxy is supposed to honor that person's previous wishes.
So what would you suggest they do if for whatever reason that doesn't seem to be the case of what's happening?
It's a difficult problem if the healthcare proxy does not appear to be supporting what the elder wanted, and it makes you look into why. Is it a financial issue? Is it they don't agree for some reason? It's very concerning, and it's something you want to get your nursing homes administration and possibly legal involved with. If it turns out to be something like a potential financial abuse, that would have to be looked into, whether the person needed guardianship. Brynn, do you want to comment on that one?
Yeah, I was going to say it is really tough when a person is not able to speak for themselves. And what makes this, if you do not suspect abuse of the kind that you were just mentioning, Dr. Aydelotte, I think, COVID was a situation that nobody anticipated, which meant that care in the hospital was dangerous in a way that it hadn't been pre-COVID. And that has bearing on people's decision-making, and it might have on the person's decision-making before they develop dementia. It certainly might on their healthcare proxy who's making decisions at that moment. So I think that the key kernel there is really helping that healthcare proxy to think through the eyes of the person about whether the new scenario would have influenced their decision-making. But it is very difficult. I agree with you there.
Right, and sometimes medical and nursing staff does have to help families, give them permission to not hospitalize, to recommend a best practice. And that was never, that's something that's changed over the past 10 years, I'll say that. But now these are such difficult struggles for families. It's perfectly reasonable to say, you know, in the setting of your mom's very advanced dementia and how sick she is, it appears that the hospital would not have a lot to offer her, you know, to help the family get to the point where they're comfortable. But you know, it is a very traumatic time with COVID for everyone. I give the families a lot of slack. The staff is stressed. We're all stressed in different ways. So to try to be supportive of people that are going through decisions that they didn't think they were going to be making at this time.
Thank you. I'm going to turn it back over to Susan.
Well, thank you both, Dr. Aydelotte and Brynn Bowman. Terrific presentations. Hang with us. I've got 3 questions. We're going to do some polls to help prepare us for the next session. So Janet, would you launch the next one? And this first one is really about testing. There's so much out there about testing and access to testing and the type of testing that you're using. So Janet, if you'd launch that poll, and we'll have everybody just respond. Which of the following best describes the COVID testing strategy you are using? Just single choice. So one answer. So you can read through them quickly and submit your responses. We're looking at point of care tests, the PCR test, you're routinely testing all staff and residents, testing only symptomatic staff and residents, routinely testing all staff only if they are symptomatic. We don't have enough tests to implement, or other, and you can put that in the chat box. All right, about a quarter of you, a little more than that, have responded. Okay, just another couple seconds. All right, Janet, you want to stop the polling and we'll see what you got. Well, it sounds like you are routinely testing, which is wonderful. So thank you for that. Let's launch the next one. And this is really about the twindemic is what they are calling it. And it really is about the convergence of COVID and the flu. So in light of the probability of the convergence of the flu and coronavirus, which of the following are you including in your plan? And this one is multiple choice. Mandatory resident flu vaccinations, mandatory staff flu vaccinations, encouragement to family members to obtain the flu vaccine, continued restriction of visitors, continued restriction of communal dining or group activities, and other. Or you don't have a plan. So please indicate your thoughts here. And the exciting thing, Dr. Al Power is going to do our didactic presentation the next session and really talk about, you know, what are some of the best practices or things we should be thinking about. So thank you so much for putting your responses here in our poll. All right, Janet, thank you. All right, 45% of you said you are doing mandatory staff flu vaccinations, 32% mandatory residents, 36% of you, encouragement of family members, 41% you're going to continue the restriction of visitors, and 36% continued restriction of communal dining. Wow, lots of strategies out there. All right, and only 14% said you don't have a plan yet. Final one, and this has to do with PPE. So the final poll with regards to PPE and really wanting to understand how much supply you have. And this is single choice. You have a 60 or more day supply of PPE, a 30-day supply. You have more than a week, but less than a month supply. We have only a week or less, or other. Let's see where you are. Just a bit more time. Okay, Janet, you can stop our poll. All right, well, this is good news. 70% of you say you have 60-day or more supply. And I do remember, Eric, your CEO, Carol Silver Elliott, she said she will not sleep without checking to see how much PPE you have stockpiled. So I think it's something everybody thinks about. But 17% say you have a 30-day supply, and 4% said a week or less than a month. That's awesome. All right, everyone, thank you so much for your time, your attendance today, your good questions. Thank you to our presenters and to our subject matter experts for being a part of this. And as I said, next session we'll deal with what they're calling the twindemic, the convergence of COVID-19 and the seasonal flu. Thanks so much, everyone, for joining, and we'll see you again in a couple weeks.
Thanks,
Take
Dr.
care.
Brynn.